Welcome once again friends for this NPTEL MOOC module on health economics. This module is considered to be unique in the sense that we are covering the latest nuances of economics with the concept of health. Health is a commodity and the health conditioning of a person derives the commodities differently. So, the demand for health is not just as a function of the kind of commodities we are seeing, rather it is in fact a function of commodities with the level of healthcare. Hence, the demand of healthcare is the title of this course, and we will discuss with the all functional form with elasticities, etc. What we have done it in the previous lecture, if you remember very well, we have dealt with the utility function or with the level of utility with the trade off between health and consumption of other goods, etc., production function for health and lifestyle choices and health. Emphasis was given on health state dependence as well. In this chapter, we will be emphasizing on the demand curve for healthcare, whether it should be inelastic or elastic. Usually we get a two type of structure depending upon the nature of commodity we are consuming. And does healthcare demand curve follow the law of demand, or is it actually violating? We will also be emphasizing. Then to validate our products which is deriving certain value for the society, and hence the elasticities are defined. We will be citing some of the examples through the randomized experiments conducted in different places. Especially we will be highlighting RAND health insurance experiment, which was in the period of 1974 to 1982. And also we will be citing the example of Oregon Medicaid study of 2012. So, food for thought for you is that are you willing to pay all your wealth for the sake of your health, or your money really matters? In the conventional theory of economics, we usually emphasize money, the medium of exchange though, but that really carrying the value of the asset. But here we are not carrying with the same voice again, with the same belief again. Money really does not matter always. It carries with certain compromisation. Okay, the health which you carry, yes, it is denominated with money with a higher value, but what state of health you are carrying really compromising your wealth. So, wealth is not everything. Okay, so are you willing to pay all your wealth for the sake of health? No, all is not the case. At least some fraction should be afforded for healthcare in order to define your commodities, which is going to be valuable and cherishing throughout your life. So, now the first question is put off before you is demand for healthcare downward sloping? How do we define quantity, that is Q, and how do you define price? If you remember our typical example, demand function is downward sloping. We usually consider here like this, P and Q demand function we take, and a function where we are actually saying Q, Q is a function of price. Okay, but actually hence we define our demand curve to be downward sloping. Whether we take P as a function of Q or P or Q as a function of P, in both the case the inverse relationship follows. Okay, and this is typically in the case of a commodities without defining healthcare. In this case is a conventional example of demand function. Yes, again demand function varies from product to product, like in the case of inelastic products, maybe very necessary products. Okay, even maybe only just like the standard example you usually take, perfect elastic case is called the insulin drugs for the diabetic patient, that is considered to be vertical. This kind of aspect you might have studied in your economic theory. So, now I am going to emphasize or derive or measure elastic demand when health as a product is considered. So, how interpretations are made when health is taken into consideration? A quick visit to the doctor's office is not equivalent to an overnight stay at the hospital. So, counting both as one unit of healthcare is not appropriate. So, the doctor's office is different than that of stay at the hospital. So, we will be emphasizing that researchers handle this difficulty by measuring separate demand curves for different kinds of care. Measuring price, how price is actually measured, whether it is paid by third party such as private health insurers or government, or whether it is from your pocket or through your premiums, or there are co-payments like insurance which I have already mentioned, co-payments or sharing basis, etc., or it is completely free. The third party, like when we are referring to as free medical care cases. So, in that case prices are obviously going to be different for the products we are referring to. Hence, elasticity and elasticity are defined. In this figure, we have two straight lines. Of course, the downward one is and another one is vertical. Downward we are referring elastic demand, and the vertical one are referring to the inelastic, and that is in fact called perfect inelastic demand curve. So, inelastic demand for good means you cannot compromise with the quantity of good. You will pay any price for it, okay, irrespective of the price of the commodity. That the interpretation is that you are supposed to have that reserved quantity in your basket of commodity. For saving a health hazard, you won't think twice about money. You are supposed to get that, okay, get that amount of healthcare products in your treatment. So, in that case, it has to be perfectly inelastic or inelastic. Whereas, elastic demand signifies the concept that people do alter their quantity demanded subject to the change in the price. If the price of Band-Aid, for example, again another healthcare product in this case, Band-Aid, there is a small might be a small injury or might require only Band-Aids that will solve your injury. That demand is of course different. When price increases to multifold, your demand will drastically fall. Therefore, that is considered to be elastic, because the responsiveness in terms of quantity is very huge as compared to price. All right. So, we are taking some real life examples and referred in one of the authors paper, Keelers et al. 1988 work. Their co-payments were actually referred. Co-payment basically who is bearing the cost. You might have read the latest references in Indian context as well. Our co-payments are actually considered to be very high. One of the measures of those co-payments is through out-of-pocket expenditure on healthcare. It is considered to be 2/3. People are actually burning huge amount from their pocket. So, at this moment, for your easy understanding, we have taken one co-payments or the payment the consumer is bearing as 25% in one case, another is called 95%. Okay. For two type of products we have cited, dental care and outpatient care, and what really happens when co-payments are different, the incidence of consultations for each of the care actually varies based on your expenditure, percentage of expenditure. When it is 1/4 of the expenditure and it is to be borne, the number of visits for the dental care of course is higher than that of higher expenditure when you are bearing. Okay. So, it is 1.06 and here it is only 0.88. The average number of consultations is calculated here as author derived. Whereas, in outpatient care, the consultations is expected to be relatively higher, but still when the co-payments are higher, this is actually declines. Okay. Now, we are supposed to identify the elastic or inelastic nature of spending or demand in both the cases. Now remember what was the microeconomic theory tells you, or the standard example of measuring price elastic demand. Okay, we are not referring to the other type of elastic demand like an income elastic demand or cross price elastic demand. Okay, we are only sticking to the price elastic demand in this context. If you remember, you might have not read microeconomics theory to before this. I am just clarifying that we usually check the with the symbol price elastic demand EDP, okay, or EP, EP, etc. D small d you can take, okay, or sometimes in different book you will find this as the symbol. Basically that is called percentage change, delta stands for change in quantity demanded with respect to of a commodity X with respect to percentage change in price. So that is precisely delta Q by Q divided into 100, delta P by P into 100. So this is here 100 cancels out, and this is precisely delta Q by Q into P by delta P. Okay. And one thing to remember from your microeconomic theory, that the relationship is considered to be negative. Here it is just a quantification, what is the magnitude of change in the percentage in both the case, but by default you are supposed to carry the minus sign, because price as compared to the demand for the product in general considered to be negative. Okay. So the equation is mentioned, but in healthcare product the nature of spending is considered to be different, the responsiveness in different products are different, hence we are calculating. Now in the co-payment case, when 25% and 95% cases are observed, I mean the rate of payments are different, and number of cases consultations are mentioned in this example. We can calculate the elastic demand for the dental one. In the first case, now your starting point is number of cases, that the Q is this first 0.88 minus delta Q. So minus 1 point this one 1.06 divided by 1.06 whole divided by this 95, this is considered to a rate, 95 minus or a proxy of price, to 95 minus 25 divided by 25. So this boils down to minus of 0.06. Now the mode of it actually give you the right value, that is basically less than 1, isn't it. So the less than 1, and in another case, that is for outpatient case, let us check, this is also 0.06, where if you start with a reverse, that is we started with the higher prices, we started with when your rate of contract or the payment increases, what really happens, we started with the new to the Q1 to the this is basically Q1 minus Q0 divided by Q0. Here on the denominator we have taken P1 minus P0 divided by P0, but when we simply change the direction, that means Q0 minus Q1 divided by Q1 and vice versa, and accordingly for the prices, the why is it so, rate of price, the rate of spending for the healthcare might increases, might decreases, hence the starting point actually gets changed. In this case this is the value, and in another example it is the value. In all the cases the absolute amount has to be compared, and in all the cases we derive that it is actually relatively inelastic. Okay. However, while comparing dental care and outpatient care, we have also presented. Now you can see dental care and an outpatient care, the relative elastic demand are also different. Okay. Here you just have a check. In the graph we have already mentioned, for this one is dental care, this one is actually outpatient care, this is DC. Dental care is actually relatively more inelastic as compared to the outpatient care. Okay. Even our findings also derived. comparing these two, you will find that this is actually relatively inelastic. Dental care is more inelastic than that of outpatient care. Okay. Let us understand the choice of starting point also mark a big difference in terms of elasticity of demand. Similarly, some other methods we used to refer in microeconomics theory called arc elastic demand. In short, we mentioned ARC in capital. Arc stand for a bending portion, the arc portion of a curve. It's considered to be like this. When the this arc is actually measured when you have a demand curve which is non-linear. Now, in case of linearity of your demand patterns, what do you mean by linearity again? When your reflections or the responsiveness of P and Q considered to be almost tending to be same in the long run, but in the short run that is considered to be linear. We project demand curve to be linear, where the previous method, price method we have just mentioned, percentage method is useful. Whereas arc is used when your demand curve is considered to be very volatile, very it is non-linear. Out of that you may project 2 points, that is 2 points of change. You want to measure what really happens from event 1 to event 2. Here event 1 place A and event 2 place B. Okay. What really happens in terms of spending patterns. So, do not you think that you have got a arc, this is actually called an arc, arc, bending portion of a sickle is called arc. Okay. So, in that case we used to take the starting point, what is the starting point? In a typical elastic demand function, we would dq by dp, dq by delta q by delta p into p by q. This p q we used to take the starting point, that is p 0 and q 0. In this case, in the arc 1, since many changes are there in a nonlinear setup, we are in order to address the changes, neutralize the changes, we are supposed to take P 0 P 1 plus Q 0 Q 1 divided by 2. Okay, this is divided by 2, this is divided by 2. So, 2 cancels out. So, the formula is actually delta Q, this is basically Q 1 minus Q 0 divided by P 1 minus P 0 into P 0 or P 1 P 0 plus P 1 whole divided by Q 0 plus Q 1, thus basically the formula. Okay. And this is what is mentioned in this example. So, arc elasticity method can also help you to derive the results. Oh, I think I have already made it. I will in the PPT will do it. We can find out the erasure and will show you what really happens. Okay. So, here now I will check the highlighter pen again. Alright. So, in this example we have also applied the arc method just to know whether there happens to be any nonlinear changes. Still we applied the arc method. Through the arc method also we have found the elastic demand is inelastic. Okay. In both the cases. However, again in the outpatient case is as compared to one is relatively more elastic than that of the dental one. So, dental is considered to be more inelastic. Okay. So, again product wise we have different approaches or different elasticity of demand, hence products should be actually marketed accordingly so far as marketing of healthcare products is concerned. So, average also matters so far as calculations of elasticity of demand for healthcare is concerned. Okay. Now, we will also cross check with this whether it is downward sloping or vertical. If it is perfectly elastic, then it will be vertical. We will be citing here some of the example from another health insurance experiment of the RAND Cooperation Institute of the RAND Cooperation, and a team of researchers at the RAND Cooperation led by the health economist Joseph Newhouse in 1971 tried to answer these questions through one of the experiment, one of the largest social experiment in the history of science. That's actually called health insurance experiment. What they try to know that if people care about their health above all, they must be ready to give any price for their health care. Okay. So, this means that they have rather a vertical demand curve, curve as well for healthcare. So, it depends upon the type of product. Any price, if they are ready to pay for it, that means it is precisely considered to be perfectly elastic. So, one experiment is called RAND HI finding or experiment. Healthcare elasticity is net zero. That is interesting aspect. There is not much of a surprise regarding RAND HI findings. Healthcare elasticity is not zero and the law of demand still holds, as you have seen in our previous examples. We will discuss the details of RAND HI in a while in our next couple of slides. So, objective here is how does cost sharing or membership in an HMO affect the use of health services compared to free care. So, then how does the cost sharing affect appropriateness and quality of care received? What are the consequences of health? So, the medical aspect etc., will be also cross check with cost sharing patterns. I will just tell you. We will concentrate on from now on a part of first objective highlighted in, that is in red. With that example, we have cited 6 counties at the downtown of USA. They are Dayton, Ohio, Seattle, Washington, Pittsburgh, Leominster, and Franklin. So, the time period of as is referred in their calculation is 1974 to 1982. 2,750 families and 7,700 individuals are considered with the age group of under 65. Participants were randomly assigned to one of 5 types of health insurance plans created specifically for the experiment. Now, since we have said this is a randomized experiment from the RAND Corporation. Now, so we will now just check what is the design they have followed. Basically, all the participants, that is of 2,700 families of the in total the participants were 7,700 individuals. So, they have actually divided into 2 first. Those are based on the cooperatives, and another one is free for service plans. And then free for service plan, that does not mean 100% free. One category may be free care, 100% free care, another is of cost sharing plans. So, we will compare with each one, since it is control as compared to treatment group. We will actually check how they are actually it is creating the difference in terms of health spending. Now, you just see what happened. This experiment is called RAND Health Insurance Experiment of 1974-82. Researchers randomly divided household into 2 groups, free care and cost sharing basis in broadly. These are mentioned here. So, just to check what is the difference. In cost sharing basis, actually again we have already cited earlier, that is 20, let us you will pay 25% and 95%. And the third category as the control group is basically the free care type. Okay. And another category, earlier we used to discuss 25%, 95%. Now, another category also they have added is called if you are paying also 50% of the payment. And fourth one is of course your free care. Okay. So, we will discuss all sort of things. In addition to that, we have already said cooperative models were also mentioned, but at this moment in the example we will discuss this 4 categories: free, 25% type, 50% type and 95% type, to find out the number of episode, the average number of annual episode by different conditions. So, here we are referring to their experiment and outcome evidence from outpatient cares particularly. So, as patient cost sharing increases, now you can see here the cost sharing 0%, 25%, cost sharing 50% and 95% as per the findings of Keeler et al. Work. So, when the cost sharing increases, it is quite obvious that the number of episode, the annual episode or the consultation is considered to be less. And again it varies from acute disease to chronic disease. So, as patient cost sharing increases, the number of episodes for outpatient care actually decreases sharply. People assigned to the 95% group had 36% fewer episodes of outpatient care than those in the free plan. Okay. So, we can compare each category, what is the difference. Both conditions had downward sloping demand. Chronic conditions especially like for example diabetes, high blood pressure, acute are actually cold or broken leg etc. But chronic are actually which is in prolonged type and which requires consistent consultations. So, accordingly the episodes actually varies. When price increases, of course the number of demand or the consultation decreases. Evidence of inpatient care, here we have also they have given in another finding by Newhouse of 1993 and in Keelers et al. They have also discussed about inpatient care. In the previous one we discussed about outpatient care. Here it is inpatient care, but Newhouse etc. discuss about emergency care. So, accordingly in your research plan you have to categorize different products, and based on that again you find in different cost sharing case this falls. Okay. And as patient cost sharing increases, the number of episode of inpatient care decreases sharply. Even for emergent or the urgent emergency conditions, the care those on the highest co-payment plan were less likely to buy care. Okay. Downward sloping demand curve for both inpatient as well as emergency care. Evidence of pediatric care is also referred from the work of Newhouse 1993 and also dental care utilization is discussed. Okay. The families on the free plan were significantly more likely to start immunizations and other preventive care with the age group. Here we have also emphasized with the age group wise categories. Now, you can imagine what extent consultations is possible, what extent the research is possible. Okay. Here we compare by expenditure their standard of living as well. Okay. Their plan free as compared to payment 95% plan with different income group wise, standard of living wise. We observe that a similar trend of downward sloping curve is observed in dental care as well. Okay. So, you can cross check and elastic demand can also be calculated based on these examples. So, you please try calculating these numbers for your confidence, and we may also ask you some question in the assignment also in the final exam. Okay. And final exam questions might be MCQ based or MSQ based, okay, or maybe a numerical number, only number, fill up the blank, you have to estimate and find out the exact number of elastic demand. Okay. So, we also define the fractional point to what digit we round up digit or the number will mention, give you the instruction correctly. So, please follow the instruction very rightly before preparation. So, we have discussed results of different healthcare uses and their elasticities. You can also find out the elasticity and arc price elasticity through percentage method and through arc method, okay, to identify whether they are elastic, inelastic or their magnitude as well. So, another one is Oregon Medicaid study of 2012, you can also follow. In that case Oregon study compared two groups of low income adult of Oregonians, people who own a 2008 lottery to receive the opportunity to apply for public health insurance coverage through Medicaid and lottery entrants. Second category is actually the lottery entrants who did not win or were not given the chance to apply for the Medicaid. So, those comparison can be made, and in effect this lottery randomly assigned insurance coverage to a subset of the winner who has got the lottery. Hence, the lottery winner tended to face lower out of pocket expenditure for health care. Okay. So, accordingly we can find out the differences. This is what is presented, like we have more funds, let us expand our Oregon health plan for only adults, low income people, like even previous one example. There are number of policy conclusions possible through these experiments, like which kind of products should be subsidized by government, since we have seen that number of episode declines, since our income quintiles are very different in the country, and they may not able to afford. And this also calls for public facilities for healthcare. This also gives a clear direction that why government should intervene. Okay, and number of conclusions are written in different papers as well. So please, when we are giving certain assignment, if it is descriptive, write it in different perspective from your word. It is really considered to be appreciative. Similarly, in Oregon Medicaid study, you can compare these two conditions. Control group is treatment group. Here, treatment group is your the Medicaid plan through the lottery, who have won. Let us use random selection using lottery. We have a waiting list of 90,000 applications. Out of that, 30,000 were drawn. Okay. So, here around 35,169 individuals who own the Oregon Medicaid lottery, and out of them, those who have signed for the access, healthcare access, and those who do not bother for this, around 40%. So, rest 60% are actually considered. So, so now accordingly, once those who have signed off, again there might be some eligibility conditions. So, after deducting the ineligible applicants, so only how many are left? 10,405, and based on that the study is applied. Okay. So, some findings based on Finkelstein et al. Of 2012 work. Here the percentage of visit and number of visit figures are given through outpatient care, inpatient care, and emergency care, which we have already mentioned the RAND corporation findings, findings also. Here the comparison is between lottery winners as compared to losers. Evidently, outpatient, inpatient, and emergency care show downward slope of demand for Medicare, and Medicaid increase with the use of healthcare services. So, now we can compare RAND, the health insurance experiment as compared to Oregon medical study. So, the RAND and Oregon experiment are different. They were performed in different population with different research questions and circumstances. Oregon study focuses on low income population, unlike RAND study. That is also important. Okay. So, whereas RAND study is national representative, that is another important direction, and RAND study used a direct randomization of health insurance coverage, while the Oregon Medicaid experiment relied on a randomized scheme that was only indirectly related to insurance coverage. And the RAND participants had multiple co-payment options, whereas here we have only choice, specific choice, that is between have and those who have not received. Participants had multiple co-payment rates, thus varying marginal cost, while in Oregon study ones selected had no marginal cost. Okay. So, similarly other differences you can note. I am not going to read between the lines. I think it will be useful for your understanding. So, based on all sort of evidences, the elasticities are also calculated based on by Newhouse 1993 paper, and in Guartney et al. 2008 study. You will find interesting aspect. Broadly speaking, we have compared elasticity and inelastic demand. You will see inpatient dental care, outpatient care, all care cases even are largely coming under inelastic demand. Similarly, some necessary products like coffee, tea, salt, etc., are also part of inelastic demand structure. Even movie, it does not as observed watching a movie, irrespective of change in the price level, people considered purchasing this. Okay, and that too, not responsiveness is not so huge, therefore it is inelastic. Whereas restaurant meal, etc., it is a reflection of the contract, the price rate. And similarly tomatoes, I mean there are many other products, usually comfort and luxury type of goods are considered to be elastic. Okay, so you can also cross check with your real life data, and it is going to be very interesting. So, what to be concluded? So, whether demand curve for healthcare is elastic or inelastic, healthcare demand is not perfectly elastic for sure. In large number of cases, both Rand's HI and Oregon's experiment confirms that healthcare demand follows the law of demand. The emergency care and inpatient care are relatively more elastic. So, we have these readings to follow. J. Bhattacharya's book et al. J. Bhattacharya et al. Book on health economics is considered to be a standard book for you. And chapter 2 we have referred here. Please have a read for further clarification. Finkelstein we have also referred in the previous lecture. Now 2020 study is relevant. Page number is also mentioned. So, Newhouse we have also referred, Newhouse book of 1993. So, it is all for your ready reference. Then what we are going to study in our successive lectures, especially in the next lecture, we will actually continue again this demand chapter, demand of healthcare. We will start specifically on Grossman's model of demand for health. So, with this it is time to close. I hope you have raised number of interesting aspects. I will be happy to receive your comments. Thank you.